Hi, I'm John Hovannessian. In this video, we're going to talk about techniques for pterygium surgery and how to make the steps of surgery easier. For more detail on the bigger picture of pterygium surgery and what techniques to use, see our textbook, which is available at slackbooks.com, or our video at bettereyesurgery.com that shows 3 easy-to-learn techniques that give high success in this procedure. What really works in pterygium surgery is to put some type of graft over the site of excision that both promotes epithelial healing and restoration of a normal surface, as well as inhibits proliferation of fibroblasts and scar tissue that would lead to recurrence. Now, I advocate not only considering the area underneath the graft, but also that surrounding it. There are really 3 techniques for doing this. One involves removing the pterygium and covering with a conjunctival autograft. An autograft is a fairly easy technique to learn and has about a 5% recurrence rate. The second technique is to use amniotic membrane instead of a conjunctival autograft. Here we also undermine and place the graft at 2 or 3 millimeters around the site of excision to prevent recurrence. This also has about a 5% recurrence rate. The third technique is to use the combination of a conjunctival autograft over the bare sclera site combined with amniotic membrane placed in the subconjunctival space around where the pterygium was removed. This technique, while slightly more complicated to learn, has a recurrence rate that is lowest in my experience at less than 1%. Now, performing surgery is much easier with a few tips, and that's what this video is all about. First, to define the excision site, come down vertically on the surface of the tissue with blunt Westcott scissors, snipping away to create sort of a dotted line pattern that's going to define where the pterygium excision is. You don't need a real wide excision to have a good both cosmetic and functional result that won't recur. Once you've made those snips, you can then lift with tooth forceps the tissues, and you'll see where they connect and how to make the excision without distorting the tissue. Using this technique gives a nice clean removal without taking too much tissue away. Next, we undermine around the graft in order to create a space where we're going to later place our amniotic membrane graft. Doing this provides an easy procedure later on when we place that graft in place. Sometimes we'll get a little bleeding here and a little cautery is necessary, but honestly, most of the time the tissues remain fairly intact with good hemostasis. We snip down so that we've got the pterygium removed or defined right up to the limbus, and then avulse the pterygium by stabilizing the globe with a Q-tip, and then simply pulling with tooth forceps. Next, we want to clean the limbus, and we do this using a 15 blade held vertically and scraping back and forth parallel to the limbus. You need to do this sometimes with a little force, not enough to cut into the tissue or leave a permanent mark, but enough to remove the residual tenons from the limbus and the residual pterygium deep aspects from the surface of the cornea. And you'll know you've done that when you see a glistening surface of the corneal stroma of Bowman's membrane after you're finished. We can create the graft from the superior limbus next by infraducting the globe either with the side of the forceps, or we can simply grasp at the inferior limbus. We next snip in order to create a tiny opening, which we then widen and explore in the very most superficial subconjunctival space. And you'll see that the tissue is almost transparent. You can see the tips of the scissors nicely through there. So we know we've not taken too much tenons. You want your graft to be about as thin as it can be while still maintaining some structural integrity so it's not going to tear as you dissect it. Once we've thinned the graft and created the graft, we can thin it further by holding it with some non-tooth forceps and then scraping toward the sclera. Sometimes we'll get a little tiny buttonhole in the graft at the edge that's toward the fornix, but in fact that will not present a problem when it's later grafted because that's away from the limbus. The graft is then left attached at the superior limbus while we tuck in the dehydrated amniotic membrane into the subconjunctival space. Now, sometimes we wet this amniotic membrane with the fibrin component of fibrin adhesive, and this is Ambio-Dry 2 from IOP Ophthalmics. Next, we cut free the graft by grasping it with non-tooth forceps, cutting it free from the superior limbus. We want to maintain its orientation, pay attention to which side goes toward the limbus. That's the side that we just cut away from the limbus. We move it so that it's epithelium to epithelium against the cornea. And next, we place the fibrin adhesive components. First, we place the thrombin component on the scleral bed there. And we can wipe away because we don't want things sliding around too much when we have the graft in place. We want a little bit of friction there. Next, we place the more viscous portion of the adhesive, which is the fibrinogen component, which comes off of a syringe that has no needle or cannula. We're going to immediately invert the graft, mixing the components of the glue, and the glue begins to polymerize slowly at this point. The graft is then stretched so that it reaches the edges of the conjunctiva where the pterygium was removed, and it's kind of amazing how far you can stretch these grafts. They're very, very elastic, and you try to keep it from sliding around in the places where you want it to stay because you want that glue to polymerize under there, giving the strongest bond possible. Now, sometimes later on we'll see a little dehiscence at the nasal edge of these grafts. That's not a problem. That doesn't lead to recurrence and doesn't even leave a cosmetic deformity. It looks really very nice as the conj heals over. At that stage, you're essentially done. You can remove any excess glue material that you see on the eye. The simplest way is to cut it away with scissors, because otherwise that will cause some discomfort for the patient. Postoperatively, we put patients on a patch that remains on overnight because we use a Marcaine block to provide 12 hours of anesthesia. We also use prednisolone acetate drops 4 times a day and then tapering over a month. We use a fluoroquinolone for a week and a nonsteroidal as well to avoid discomfort. I typically see patients a week after surgery and then again depending on our concern for pressure elevations. Healing after autograft surgery is fairly variable. Some cases will have a lot of subconjunctival blood, some fairly little. Sometimes we'll see a little gap at the edge or a little movement of the edge of the graft, but in fact most of those cases can be left alone and will heal very uneventfully over time. In summary, using the techniques with conjunctival autografts and fibrin adhesive, as well as the adjunctive use of amniotic membrane, is fairly easy and is highly effective at providing a good cosmetic result, good comfort after surgery, and a very, very low rate of recurrence after pterygium surgery. I'm John Hovannessian. Thanks for watching.